Hi there and welcome to this video brought to you by Atoza. My name is Garth. In this video we are going to be looking at the preoperative anesthetic patient assessment. The role of the anesthetist extends far further than just making people sleep and waking them up, or getting the patient through the surgery. As an anesthetist, I prefer to consider myself a perioperative physician, with roles that include preparing and optimizing patients for surgery and anesthesia, collaborating with surgeons to decide on which surgical or treatment options may best suit individual patients, counseling patients and their families on the perioperative process, including alleviating fears and anxiety, setting realistic expectations, discussing risks and benefits of the anesthesia, and then also discussing the post-operative course. I also need to plan and implement an anesthetic technique that best suits the individual patient and the type of surgery, and try to control physiological responses to the above in order to prevent patient harm. I need to plan for the post-operative care and treatment required after the surgery, taking into account the patient's individual needs and risks. The preoperative assessment is where this process begins, and most often it forms the framework for everything to follow. The preoperative assessment has many purposes. Firstly, to establish rapport with the patient by introducing yourself and your role. Many patients don't know much about anesthetists or anesthetics. We need to try to alleviate anxieties, fears, and to set realistic expectations. We need to assess the patient's health and suitability for anesthesia and surgery, which includes assessing their medical comorbidities, their surgical comorbidities, and their prior anesthetic exposures. We need to formulate an anesthetic plan, which includes the location and timing of the surgery, optimization and preparation of the patient for surgery, our intraoperative plan, and the post-operative care. We then need to counsel the patient on the perioperative plan, including the risks and benefits of any proposed technique, and to obtain consent for our anesthesia. Patients presenting for surgery are often scared, anxious, sometimes facing serious ill health or life-threatening diagnoses. Where they have had time to meet the surgeon days before the surgery, they most often meet the anesthetist in the hospital on the day of the surgery in a very vulnerable state. The old stereotype of the anesthetist is someone who asks a lot of medical questions that sound serious but doesn't connect with the patient. I try to break this mold at every consultation. I try to establish rapport with the patient by introducing myself and stating my role, by offering sympathy to the patient that they are in the health situation that they face and that they require surgery. I try to normalize any feelings of fear or anxiety. I try to allow the patient to express their specific concerns or worries about the surgery and their anesthetic. I often ask the patient if there is a friend or family member that I can keep in contact with during the surgery and after the surgery to let them know how things have gone and to let them know when the surgery is finished, so that they don't worry at home or at work about what is happening to their loved one. Just to give you an example of how this engagement with the patient flows in my clinical practice, these are some of the types of things that I say to patients. I normally start by saying, "Hello, my name is Dr. Garth Horston. I'm the anesthetist for your surgery today or whenever it is. That means I'm the doctor who takes care of you while the operation is taking place to ensure your comfort and your safety. How are you feeling today?" Most patients here will tell me a little bit about their health at present, and then they'll say that they are anxious or nervous or worried. I then normally say to them, "I'm sorry that you are going through this, and that you need this surgery. It's always a little scary coming to hospital and putting your trust in a complete stranger. But I want you to know that I and everyone here today is here because they care about you and they want your surgery to be a success. It's at this point that I often ask the patient if there is someone at home that they would like me to call when the surgery is finished, in case they are worrying, so that I can tell them the surgery is over and I can explain to them how things went. Most patients and families respond really well to this gesture, and I use it as a way of communicating that I genuinely care about their emotional well-being too. After this sort of introductory phase, it's clear that some patients are ready to proceed with the consultation, but others may need a little more informal chatting to help them settle. It takes experience to read the situation, but lines that I use to help patients relax are, "Have you always lived in this area, or have you moved here recently, or are you from out of town? You look like a fit, active person. What are the hobbies you do that keep you so fit? Are you a mom? Who is looking after your children today while you're in hospital?" These lines help show the patient that I'm interested in them as a person and not just as a patient in a bed. It also allows them to talk a little bit more about their personal situation, and it's amazing how often the fears or anxieties about their home situation come out during these conversations. I then start with the medical side of the consultation, which usually follows this pattern of history, examination, special investigations, counseling on the anesthetic plan, including any questions and answers and taking consent, and then optimization and prescription of any pre-medication if needed. The anesthetic consultation can be a very daunting experience, as one never knows what medical problems one is going to encounter. We hope that high-risk, complex patients have been flagged by the surgeon or a hospital pre-admissions clinic if the hospital has one, and that we are seeing these patients well in advance of their surgery to allow time for a proper assessment and planning. But the reality is that most patients are only seen by anesthetists on the day of the surgery. We also hope that patients know their medical history, their diagnoses, their treatment, and that their medical conditions are well controlled and stable at the time of surgery. Unfortunately, again, this isn't the reality. Patients often present with undiagnosed medical problems or problems that are not optimally treated. So as anesthetists, we have to be prepared to face any number of medical issues, diagnosed or undiagnosed, and then decide on what the safest course of action is. But where does this leave us? Terrified of danger around every corner? To start with, possibly. But with the acquisition of knowledge, skill, and experience, this luck of the draw feeling can be safely managed. A good framework for you to have in mind with respect to acquiring any knowledge is, there will be things that you know. This is great. Perhaps you know them from a previous case or a tutorial you attended or from your own reading. You can confidently proceed in managing these scenarios because you know what to do. Then there will be things that you know you don't know. This is also a safe scenario, as the solution is clear. You need to get help from a colleague, a senior, or possibly even a handbook of anesthesia. You need more skill and knowledge to proceed here. And then there are things that you don't know. This is dangerous, and we all start out in this situation. Medicine is big, and there's a lot of stuff that we don't even realize we don't know. My 2 pieces of advice to overcome this problem are: firstly, to start with, read broadly around medicine topics. Don't try to memorize or fully understand. but read to get a feel of the complexities that are out there. A good example here would be to have a quick overview read on valvular heart disease and anesthesia. By doing this, you'll quickly realize that valvular heart disease and anesthesia is a serious issue that requires expert skill in managing these patients. You don't have to learn how to do it yet, but you do need to know that you need help. And then secondly, to assume that abnormal findings are serious and require careful consideration. Don't overlook abnormal findings. You need to lower your threshold for seeking help, advice, and you need to read further to reduce the chance of error. So, moving on to history taking. I have a few tricks in history taking that I use to help this process. I normally start with open-ended questions to allow the patient to explain their health in their own terms. And this allows me to get an idea of the patient's medical insight. I ask them, "How is your health in general?" Or, "Do you have any medical issues you think I should know about?" This will often take me down a line of questioning and assessment that is of significant value. I always, though, follow this up with a systematic inquiry of multiple organ systems to allow the patient to add information or detail that they may not have mentioned and to remove key concerns from my list of worries. So, starting with the cardiovascular system, I ask every patient, do you have high blood pressure? Have you ever had a heart attack or a stent in your heart? Have you ever had an arrhythmia? And have you ever had a heart murmur? Do you suffer from chest pain, shortness of breath, palpitations, or dizziness? On the respiratory system, I ask, are you asthmatic? Have you ever had pneumonia? Have you ever had tuberculosis? Do you feel sick or have a sore throat at present? Do you smoke? For the renal system, I ask, have you ever had kidney or bladder problems or difficulty passing urine? For the central nervous system, I ask, have you ever had a stroke, a TIA, a seizure, dizzy spells, or unexpected falls? Do you or any of your family members suffer from diseases of muscles that cause muscle weakness? For the hematological system, I ask, do you or your family members suffer from excessive clotting or excessive bleeding? Are you on any blood thinners or antiplatelet drugs? For the metabolic system, I ask, are you diabetic? Do you have any thyroid problems? For women's health, I ask the patients, is there any chance you may be pregnant? Are you on HRT? Are you on a contraceptive? For the gastrointestinal system, I ask, do you suffer from reflux, heartburn, or stomach ulcers? This focused system-based line of questioning specifically addresses medical conditions that I am concerned about, but the patient may have failed to mention earlier. Obviously, when the patient reports a medical issue, the line of questioning needs to uncover more information about that condition. As an aside, we hope to create another lecture series in the near future to cover common medical conditions encountered in anesthesia. But for now, this video lecture is an overview of the preoperative assessment. So after taking a medical history, we then need to take a surgical history, including about previous anesthetic exposures, techniques, complications, the patient's experience of the event, and how the postoperative course went. I then ask the patient to tell me all the medication they use, including alternative medications, and I write the list down. At this time, I ask about food and drug allergies. And lastly, I assess the fasting status of the patient. When was their last solid meal or non-clear fluid? When was their last drink of clear fluid? Having taken a thorough history, I'm able then to perform a focused clinical examination to answer my patient-specific concerns. So it's a focused examination, but I still want to do a general systematic approach so that I don't miss any undiagnosed problems. I want to assess the general health of the patient, looking for jaundice, pallor, edema, clubbing, cyanosis, their nail health, their skin appearance, their anxiety levels, their weight, their comfort at rest. I then want to do a respiratory examination. It's just a general assessment if they have no risk factors, but if they have respiratory disease, then I want to look for specific things. So in asthmatics, I want to examine for wheeze, hyperinflation, soft breath sounds, a weak cough, breathlessness. In COPD patients, I want to look for cyanosis. I want to check their baseline saturations, assess for lower respiratory tract infection, and again, also assess for wheezes and the quality of air entry. In patients who've had previous tuberculosis, I want to look for features of clubbing, amphoric breathing, diffuse crepitations, which might suggest bronchiectasis or large cavitations within the chest. I also want to look for chest and spine deformities in certain patients, because those can significantly impair my intraoperative and postoperative ventilation. Respiratory distress preoperatively for any cause is obviously a big worry for intraoperative problems and the need for intensive care postoperatively. In assessing the cardiovascular system, obviously we need to look at the blood pressure, the heart rate, and the heart rhythm. We want to look for features of heart failure in certain patients, assess for valvular murmurs. My abdominal examination is normally fairly superficial in healthy patients presenting for elective surgery, but I do want to assess the weight and the abdominal girth, because this can impact on my airway management and my ventilation. In pregnant patients, I like to always palpate the abdomen of pregnant patients presenting for emergency cesarean section, because things can change so rapidly in the pregnant patient. And I think that my input here can really help and can change my anesthetic plan based on my findings. For the central nervous system, again, for most patients, this is a fairly superficial assessment. Obviously, in patients with a history of neurological disease, or in patients where you find neurological disease, that is a big worry, and probably only experienced anesthetists should be looking after these patients. And then we have to do a more thorough neurological examination. But things that are of particular concern to the anesthetist would be the airway bulbar strength and reflexes in terms of swallow, cough, choking, gag reflex, your respiratory muscle and diaphragmatic strength in terms of your tidal volumes and your ability to cough and generate pressure, and then features of general weakness or muscle disease, because that will affect the drugs that we use intraoperatively, especially our neuromuscular blocking drugs. We then move on to our airway assessment, and this is such a big topic in anesthesia. We actually have a separate video on assessing and managing the airway, so look out for those videos. So following a thorough history and examination, one should have a good idea of the general health status of the patient. We may still require special investigations, though, to assess the full extent of the patient's medical condition, to rule out disease-specific concerns, to understand physiological baselines, and then to make a safe anesthetic plan. And there are numerous special investigations that can be done, but we'll just go through some of the common ones that I perform. So every patient presenting for surgery should have a minimum of a baseline finger prick hemoglobin and a random glucose level. Certain patients may require a full blood count, and these will be patients with significant respiratory disease, heart disease, renal disease, or patients presenting for major surgery or surgery with the potential for significant blood loss. Some patients may also require a urea, creatinine, and electrolyte test. Again, these are patients with heart disease, renal disease, diabetes, or those presenting for major surgery or surgery with a chance of significant blood loss. Chest X-rays. In my setting, these are examinations that I very seldomly perform, because I feel I can get an excellent understanding of the patient's respiratory function from my history and my clinical examination. But there are patients where a chest X-ray is essential, and this is if I suspect bullous lung disease, low respiratory tract infections, pneumothorax, rib fractures, pleural effusions, and other things. ECGs or electrocardiograms are safe, cheap tests that we should have a fairly low threshold of performing, and I request these on patients with significant medical problems, heart disease, or patients over the age of 50. Thyroid function tests are slightly more problematic because they're normally not available on the same day that you take the blood. But patients with thyroid disease or features of thyroid disease should have a thyroid function test prior to their surgery. In patients who have been on thyroid medication for some time, if their GPs have done tests in the last 12 months and there was no change in their medication or treatment following those tests, then I'm normally happy to proceed based on the patient's account of that. But ideally, one should still try to get hold of those thyroid function test results. And if the patient has unstable thyroid disease or severe symptoms of thyroid disease, then surgery should be delayed until the thyroid function has been assessed. Lung function tests are necessary in patients that have got poorly controlled asthma or significant chronic lung disease. They're expensive and they are only available in limited setting. In uncontrolled asthmatics or patients with significant chronic lung disease, these patients should not be anesthetized by learning or trainee anesthetists, and so we won't go into the details of when to order lung function tests or how to interpret them. The same goes for echocardiograms, which are ultrasounds of the heart, in patients with suspected valvular heart disease or features of heart failure. Performing a preoperative echocardiogram can be of significant value. Again, these patients are not meant to be anesthetized by training learning anesthetists, and so it's beyond the scope of this talk. A simple test to perform when you are trying to work out whether a patient is of high cardiovascular risk or normal cardiovascular risk can be to perform a pro-BNP preoperatively. And this can help us reclassify patients based on our history and examination into either high risk or low risk categories. And it's a test that I perform regularly in high risk patients undergoing high risk surgery. But again, it's probably beyond the scope of this talk, but I just include it here because it is a very topical test for helping improve the accuracy of our preoperative risk assessment. So following this comprehensive assessment of the patient, one should have a good estimation of the risk the patient faces in the perioperative period. There are numerous risk assessment tools or models, and the simplest one that we use is the ASA classification, where ASA1 is a normal healthy patient, ASA2 is a patient with mild systemic disease, such as well-controlled hypertension, diabetes, asthma, or epilepsy. And then going into the more high-risk patients, ASA3 are patients with severe systemic disease that causes functional limitation, such as poorly controlled hypertension, poorly controlled diabetes or asthma or epilepsy, or patients with target organ damage, such as ischemic heart disease, cerebral vascular disease, or cardiac failure. ASA4 are patients with severe systemic disease that is a constant threat to life, such as a recent heart attack or stroke, decompensated heart failure, severe valvular heart disease, end-stage kidney disease, COPD on home oxygen. And then stage 5 are extremely sick patients who have a high chance of dying in the next few days with or without their surgery. ASA6 patients are patients who have suffered brain death and are for organ donation. So based on our assessment of the patient, we should now be able to decide whether to proceed with surgery as planned and the anesthetic and post-operative plan required, delay the surgery pending further investigation and or optimization of the patient, or reschedule the surgery at a more appropriate time or a better venue equipped to manage the patient, or with a more experienced anaesthetist. We should also be in a position to decide how best to perform the anesthesia for this procedure. Are we going to do sedation versus anesthesia? Are we going to use a regional anesthetic technique or general anesthesia? What is our airway management plan? What monitoring is required during our anesthetic? What is our analgesia plan? And then what is the plan for post-operative care and monitoring? And so at this time, we can relay this plan to the patient and sometimes also to the patient's family, where the patient has given consent for that, because it's important that they understand the plan and the risks and that they have realistic expectations. So we relay this plan to the patient in the form of counseling and consent. Let's now chat about pre-medication and fasting. So routine use of sedative or anxiolytic pre-medication has gone out of favor, as they tend to contribute to post-operative drowsiness and even delirium. But there are some patients who are very anxious, and for those patients I still give them a preoperative sedating and anxiolytic medication, and this is normally midazolam, 5 or 7.5 milligrams orally, 30 to 60 minutes preoperatively. And we just have to always be aware of patients who are at risk of oversedation or who may have respiratory compromise with sedation. And so for these patients, if I am going to give them midazolam, I want them to be in a monitored setting. So this might mean that they come through to the recovery room preoperatively and they get their sedative in the recovery room before they come through to theatre, or they are in a monitored setting in the ward. For patients who have a needle phobia, EMLA cream placed under a plaster 60 minutes preoperatively can help. Although patients with a true phobia are not scared about pain, they are genuinely scared about the needle. And the EMLA cream isn't going to solve that problem. And so for these patients, then I'll also give them a sedative and anxiolytic pre-medication, or I will counsel them for a gas induction if it is possible to do that. For pregnant patients or patients with gastroesophageal reflux disorder, we want to give them a PPI. So for example, a omeprazole, ideally 40 milligrams orally the night before the surgery, and then 2 hours preoperatively on the day of the surgery. One can also give these patients metoclopramide, 10 milligrams intravenously, 45 minutes preoperatively, and we can give them sodium citrate, 30 ml orally en route to theatre. For most patients, if we're trying to be cost effective in our multimodal analgesic strategy, we should be giving them oral paracetamol and an oral anti-inflammatory drug with a sip of water 2 hours preoperatively. And I cover this more in the talk on analgesia. In terms of our fasting guidelines, the guidelines are that patients are allowed to have a light meal not sooner than 6 hours pre-op. I've never actually worked out what a light meal is, but I presume that it's not, steak and potatoes or something like that, maybe a sandwich or a bowl of breakfast. So I don't know how long you actually have to wait if you've had a full, heavy, big meal, but the guidelines say that you shouldn't have had solid food within 6 hours preoperatively. Patients can drink water or clear fluids up until 2 hours preoperatively. And clear fluids will include apple juice, black tea, black coffee, fizzy drinks like Coke or Sprite or something like that, up until 2 hours preoperatively. Anything that contains milk or milk products is considered a solid or a particulate liquid, and so one would have to wait 6 hours after having a milk-containing liquid. So that concludes this video on the preoperative assessment. As I said at the beginning, it feels like the preoperative anesthetic assessment can include the whole of medicine. You can uncover any medical condition, and I frequently come across patients with diseases or disorders that I've never seen before, or sometimes never even read about in a textbook. And at the beginning, it's obviously extremely stressful when you come across these patients, but with time, you develop the confidence and the skill to put patients into different categories and to apply broad management principles to patients. And then now with the information technology that we have available, we can always research medical conditions quite rapidly, and one must never be scared to talk to colleagues or to ask for help or enlist the advice of senior or more experienced anesthetists. And then, like I said, just to emphasize again, the biggest risk is not knowing what we don't know. And so don't overlook any medical condition or any clinical sign or an abnormal finding as being insignificant. Always apply your mind to the problems that you find, and then you won't get yourself into a situation that you can't handle or you can't manage. So I hope this video has been useful for you. It certainly has been useful for me re-looking at these aspects of my practice. And as always, we're open to feedback and comments and suggestion, and you can send those through to us via email. And I hope you're enjoying this video series, and thank you for subscribing.